So Dr. Nason, I think we could actually get started. We
Sounds
have
good.
21 people inside the waiting room. So welcome everyone. Thank you so much for being here with us today for the first webinar we have for the calendar year 2022. Super excited to be here with everyone. Our guest lecturer today is Dr. Dana Nason. I'm sorry, I already mispronounced her name, even though I just learned it. Dr. Nason was born in Toronto, Canada, and attended medical school at the University of Virginia, followed by a pediatric residency at the University of Connecticut and their Children's Medical Center. She's since worked since 2018 as a primary care pediatrician in Indianapolis. And as some of you may have heard, she is currently in Toronto again. And she will still be beginning a fellowship in pediatric hospital medicine at the Advocates Children's Hospital in Chicago, Illinois. So I'll pass the floor over to our guest lecturer today.
Hi, everyone. Welcome. Thanks so much for joining this evening, afternoon for our time. So I am presenting today on acute diarrheal disease and fluid management in children. And I know you guys requested this topic, so you understand how important it is. I want to start by saying I have no financial disclosures, and we'll be happy to take questions at the end of the presentation. So to start, just for what I'm planning on talking about today, so I want to go over why this topic is important. Then I want to talk about the main causes of diarrheal disease in children, because we hope kids don't get sick, the best preventative measures, and then if a child comes into your clinic with diarrheal disease, how to best assess them, looking for signs of dehydration, and then next best courses of action for that child. Should they be admitted to the hospital, or what's the mainstay of treatment in the outpatient setting? And then I'll end this talk briefly by discussing how to manage children in the hospital setting and the need for IV fluids. So as you are all probably aware, this is a really important topic. Per the World Health Organization, globally, there are nearly 1.7 billion cases of childhood diarrhea disease every year. Also worsening the situation, infants and young children are susceptible to multiple bouts of diarrhea disease every year. So even if they got sick once, that doesn't mean they can't get sick again and again and again. And diarrheal disease unfortunately kills over 500,000 children under the age of 5, making it the second leading cause of death in this age group. And if you see on the chart, if you ignore the neonatal deaths, which are kids between 0 and 1 month, after respiratory illnesses, diarrhea disease is the second leading cause of death in this age group. Unfortunately, most of this burden is in both Asian and African countries. There was a study that I found from the Kenya Demographic Survey in 2014 that the national prevalence of diarrhea disease under the age of 5 was around 15% in a year. In addition to being a leading cause of death, diarrhea disease can contribute to childhood malnutrition, and there's a bidirectional relationship between having frequent bouts of diarrhea and nutritional absorption leads malnutrition, and a child who's already being malnourished being at increased risk for death from diarrhea disease. Furthermore, indirectly through its relationship with malnutrition, diarrheal disease can impair a child's growth and development and make children more susceptible for severe illness and other infectious diseases such as pneumonia or UTI. Additionally, there's an economic cost, both directly to the family from taking care of the medical costs of treating kids with diarrheal disease, and also from decreased productivity, having to miss work associated with diarrheal disease are huge, especially considering a population that you work with a lot of individuals below the international poverty line, and with children conveying multiple bouts of diarrhea disease in a given year. The good news is that even though this is a major problem, it can easily be prevented and treated. And that's what I'm going to go through on the rest of my lecture. So I want to start with some definitions to make sure we're all on the same page. So what is diarrhea? So according to the World Health Organization, it's defined as the passage of 3 or more loose stools or liquid stools per a 24-hour period, or more frequent passage than is normal for an individual. So if you ask children to describe what their diarrhea looks like, typically families will say it will look like a porridge or a gravy consistency on the stool chart. And one thing to note is, especially in young infants or breastfed infants, often they can have multiple stools in a day that are often like a pasty yellow consistency, and that's normal for breastfed infants. So that's why the definition includes the caveat, more frequent passage than is normal for the individual. And then we sort of think about how to best classify diarrheal disease. So we're going to focus on what we call acute diarrheal disease, which is diarrhea that's lasting less than 14 days. If it's lasting more than 14 days, that's considered persistent diarrheal disease. And some classifications will actually subdivide this into persistent diarrhea lasting between 14 days and 1 month, and then chronic diarrhea lasting longer than a month. Some other individuals will just group it as persistent diarrhea lasting anything longer than 14 days. And that's sort of a separate topic for a different talks, and so it requires different workup and different management. Another thing that's important to consider for diarrhea is if it's more watery versus bloody. And synonyms that you might hear for bloody diarrhea include dysentery or invasive diarrhea, and they'll all mean exactly the same thing. So what causes diarrhea illness in children? So the vast majority of acute diarrheal illness in children is due to infectious causes, either viruses, bacteria, parasites. And as you can see here, rotavirus is probably the biggest cause in young children. The exact distribution varies by both age and country. In one study, I'm sorry for my pronunciation, I think it's out of Nyanza province. You guys can correct my pronunciation on that. Rotavirus, Cryptosporidium, Shigella, and E. coli cause the vast majority of moderate to severe cases of diarrhea in children under 5. If you were to generalize something, Cryptosporidium is seen in children under 1. Rotavirus tends to be more common in children under 2. While Shigella and E. coli are more common in children 2 to 5. But again, that can all overlap depending on your exact geography and population. I do want to make just one little note of this box here for cholera. So cholera tends to occur in outbreaks in a community versus in individual cases in children. Like other causes of diarrhea, it's caused by consuming contaminated food and water, but it's characterized by rapid onset, large volume watery stools, and would need immediate treatment. So if you do have a cholera outbreak in your community, just be aware. And then in addition to the causes seen on the slide, you also have to think about more systemic disease, with diarrhea being one of the presenting symptoms. So things like influenza, measles, dengue fever, HIV, malaria, UTIs, pneumonia, sepsis can all have diarrhea as one of their presenting symptoms, but should have other signs too: fevers, rashes, lung signs, focal signs on respiratory exam, etc., to make you suggest that's not a GI bug, but something else that requires treatment. Sorry, my computer just told me that it needs an update, so I just ignore that. And then you also have to think about, for severe abdominal pain with diarrhea, surgical emergencies, such as appendicitis, intussusception, that can present with diarrhea, but there should be, the abdominal pain in those situations should be out of proportion to the diarrheal symptoms. So the vast majority, if you were to generalize, are infectious. So since prevention is the best cure, and we really don't want kids getting sick if we can help it, really talking to your families about prevention, either when you see them for a diarrheal disease or during their well visits, or if they come in for vaccines, is really a very important thing to do. So water and food contamination with both human and animal feces is a major source of diarrheal disease. So focusing on improving clean water, both to your patients and communities at large, ensuring adequate sanitation in the community, and emphasizing hand washing is some important points to reduce diarrheal disease. So if you want to give families more specifics, some things that you can talk about is to hand wash with soap after stooling, changing a child's diaper, disposing of a child's stool, and before preparing meals and before eating. Also, on more of a community level, washrooms, latrines should be located 10 meters and downhill from drinking water, or any runoff should be avoided to go into farm fields, because you don't want human feces contaminating the drinking water or the fruits and vegetables that you're growing in the community. And then if a community is collecting and storing water, make sure they're using clean containers and every day rinsing them out, and not letting either children or animals drink directly from the water, which increases the risk of contamination for everyone in the community. So there's a couple of other things to think about in terms of prevention. So encouraging moms to breastfeed, and this is something that you can encourage the midwives or the OBs that you work with to also talk about, or the family docs. And the World Health Organization recommends exclusive breastfeeding under the age of 6 months, and to continue breastfeeding with the introduction of complementary foods until 2 years of age. And the reason why breastfeeding is such a good source to prevent diarrhea is A, you're not exposing very young infants to unclean water sources, or such as if you were to use unclean water to mix formula or even to clean out the bottles, there's no contamination there. In addition, breast milk contains immunological properties that protect the infant from infections, and they've shown infants who breastfeed not only have decreases of diarrheal disease, but also pneumonia and ear infections. It also is a complete nutritional source of food for the first 6 months of life, so it protects against malnutrition, which is a key contributor to severe diarrheal disease. The other thing, which I know Kenya has been working really hard to do in the community, which is great, is to work on vaccination rates with the rotavirus vaccine. I know unfortunately, the COVID-19 pandemic has put a little hamper on that campaign, but really trying to get your infants between the ages of 6 weeks and ideally in the first 6 months, but up to 8 months vaccinated with the rotavirus vaccine. And it's an oral vaccine. It's given depending on which brand you use in 2 to 3 doses over the first couple months of life. In talking about vaccines in areas where risk of cholera outbreaks, there is an oral cholera vaccine that's recommended, but generally it's not recommended for all individuals, only in outbreak setting. So changing topics slightly, you're unfortunately seeing a patient in clinic for diarrheal disease. What type of history should you start taking from the family? So the first thing you want to know is how long the diarrhea has been lasting to see if it's more acute or chronic issue. Then is it blood or is it more watery? How many stools is a child having a day? And sometimes I like asking how often they're changing a diaper because that's an easy gauge for families for younger kids. You also want to know some ideas in terms of the hydration status. So is the child urinating? Are they producing wet diapers? Are they less full than normal? And then are they keeping stuff down? So are they having vomiting? If so, multiple episodes, single episodes. And then you want to know about other symptoms: abdominal pain, fever, cough, trouble breathing. And then you want to start thinking about what's causing it. So their pre-illness feeding patterns, including source of water, if they're drinking raw water, if they're drinking possibly stream water or some source of contamination. And then during the illness, how much fluids have they been keeping down? So are they keeping down anything, breast milk, food, etc.? And then what has family tried at home? So I know lots of communities will try things like herbal remedies, teas. Some of them are fine, some of them can actually be dangerous, so you want to know what's tried at home. And then for community-wide outbreaks, anyone in the household or community with similar symptoms, and then any history that could put them at increased risk for severe disease. So being immunocompromised, including having history of HIV, malnutrition, or being an extremely premature baby. Then, if possible, you would ideally want to look at their stool. So in general, diarrhea is divided into acute watery versus bloody. So for acute watery stools, does it have more of a greeny yellow color? And that's often seen in rotavirus, but can also be seen with enterotoxigenic E. coli and cryptosporidium. If you see rice water color stools, that's very characteristic and pathognomonic of severe cholera. If you see bloody stools, and of note by bloody, it can be bright red blood, but it can also be just slightly tinged blood in the diaper, or it can be black blood, because that's more digested blood from up above in the GI tract. If you see bloody stools, Shigella should be the first thing you're thinking of in the community in kids, but it can also be caused by Salmonella, Campylobacter, other E. coli species, and also the parasite Entamedia histolytica. But Shigella is definitely the mainstay cause of bloody diarrhea in children. So then, of course, you want to look at your patient. So often you can tell a lot about how sick a child is just by looking at them, if their parents are holding them or playing with them. Are they interested in playing? Are they being sleepy, irritable, lethargic? One of the mainstays of exam is looking for, is the child dehydrated? So on my next slide, I'm going to review some of the signs of dehydration. But one of the quickest ways initially is if you have a recent weight on the child, to compare. So what % weight are they down if you've seen them, say, recently 2-3 weeks ago for a well visit, if mom knows their weight. Then you want to do a complete head to toe exam for anything else going on. Also, that can also tell how sick they are based on heart rate, respiratory rate, etc. Then you want to look for complicating factors, like is a child malnourished, and putting them on a growth chart can help to see what percentile they fall. And the other way, if you don't have access to a growth chart to look for malnourished, is to undress the child and observe the shoulders, arms, buttocks, thighs for evidence of muscle wasting and also looking at the feet for edema. And both of those signs are signs of severe malnourishment that requires, if a child's coming in for a diarrheal disease, actually hospitalization. And then as part of your clinic exam, you always want to offer them some fluids in clinic and see if they're interested in drinking. So one of the best ways to tell, to assess a child with diarrhea is you have to know how dehydrated the child is initially. So both the World Health Organization and the CDC sort of define dehydration into sort of 3 categories: minimal to no dehydration, which means they've lost less than 3% of the body weight; mild to moderate dehydration, which means they've lost around 3 to 9% of the body weight. Of note, depending on which table you use, some people say minimal is less than 5 or 3%, but I'm using the 3% cutoff just for simplicity. And then severe dehydration, which is greater than 9% loss of body weight. So there's many different things that you can look at to assess dehydration. The ones with the orange arrows are the ones that the World Health Organization emphasizes as really the best and easiest to use signs to assess a child's level of dehydration. So the first one is mental status, which you can do very easily just by walking in the room. Thirst, which you can do by offering the child liquid in clinic. Eyes, which is sometimes slightly harder to do, but in terms of slightly sunken versus deeply sunken, but paying attention to that. And skin folds, which if you hold your hand up in an older child and pinch it, it should automatically recoil. In younger kids, you can also do it on the abdomen fat and see that level of recoil. And typically it should be automatic, but in severe dehydration, it will take longer than 2 seconds. In younger babies, you can also look at the soft spot on the head, the fontanelle, and see if that seems sunken or not. And based on those signs, you sort of categorize, are they the degree of dehydration? So for example, if you have a child, a 10-kilogram child who's showing mild to moderate signs of dehydration, they might be a little bit tired, but they're still thirsty. They are having slightly wet diapers, then they will have a fluid deficit of around 500 to 1,000 mLs that would need to be made up. So you're seeing a child in clinic and parents ask, does any test need to be done or on the child? So typically for diarrhea disease, no testing or imaging is required. There is a couple of exceptions to that statement. The first is if you have a child with severe diarrhea with altered level of consciousness, so it's actually lethargic at all or unfortunately unconscious, you really want to get electrolytes on them. And that's because they can be hypoglycemic, their sugar stores can be too low, they can have sodium imbalance in either hypo or hypernatremia. So if parents are feeding them just water, they can be hyponatremic, or if they're losing just too much water in their stool, or if they've been just very dehydrated, they can actually be hypernatremic. And also if they're just replacing the fluids just with water, they can actually have too low potassium stores, so they can be hypokalemic too. But in most cases with appropriate rehydration, electrolytes aren't needed except in those severe cases. If you're concerned about cholera in the community, you really want it because you want to do immediate treatment and also for epidemiological reasons, you really want to do a microscopy on them to actually see the cholera under the microscope. For bloody diarrhea, typically in the vast majority of cases, as I mentioned, is caused by Shigella. But if it's not responding to treatment for Shigella, there is concern for the parasite Entomia histolytica, which causes amniobiasis. So you would want to do stool microscopy after a couple of days of not responding appropriately to antibiotics in that case, because they would need antiparasitics. And then if they're having severe abdominal pain out of proportion to the diarrheal symptoms, you want to consider imaging, depending on your availability, either an X-ray, ultrasound, CT to look for intussusception, appendicitis. Also in Shigella, you can get actually a surgical abdomen too as a severe complication. So now that you assess the child, what should you do in terms of treatment? So this is a protocol that I'm going to go over in more detail in terms of steps that was published in 2016 from the Kenya Ministry of Health that about managing diarrheal disease in children 1 month to 5 years. And it bases its management in terms of how severely dehydrated the child is. So for overviews in terms of management, there's sort of 3 main objectives, or actually 4 main objectives for treating a child for diarrheal disease. The first one is to treat dehydration if it's already present by replacing the fluid deficit that the child's already lost. The second is if the child's not already dehydrated, to prevent the child from becoming dehydrated, or once you correct the fluid deficit, to keep the child hydrated at that point. And this is done by keeping up with replacing ongoing fluid losses in the stool. The third is to prevent nutritional damage from this illness through adequate nutrition during and following the diarrheal episode. And 4, to reduce the duration and severity of the episodes. So I think the first thing that you always want to consider is this patient appropriate to be managed in the clinic setting, to go home and then follow up with the outpatient, or would this child need hospitalization? And a lot of this is a judgment call. There's no real hard and fast rules, but these are some things to consider of children that should probably be managed in a hospital setting and not in your community. So the first thing is children less than 1 month of age. Children 1 month of age can A, become dehydrated and malnourished very quickly. B, they often don't show symptoms as clearly as other kids. So really they're just at high risk for complications. So I would consider hospitalization for that age group. Children with severe malnutrition, immunocompromised states, and significant prematurity. The other thing to note with severe malnutrition, it can make it extremely difficult to determine the degree of dehydration. And also these children can be at risk for complications during rehydration. So they require close monitoring for rehydration and refeeding syndrome, which is best done in the hospital setting. If they're, of course, ill appearing, severely dehydrated, or fail or rehydration in the outpatient setting, such as secondary to repetitive frequent vomiting, restless, fatigue, lethargy, because if they're not keeping themselves hydrated, outpatient, there's no way for them to go home. The other thing to consider is the situation where you practice. So if the child's one of those gray zone cases, how hard would it be for you to follow up with the family? How hard is it financially on the family to go to the hospital setting? If you send the child home and they worsen, would they be able to follow up? So you know your families really well. Just take that into account when you're counseling if you think they should be hospitalized or not. So in terms of treatment, the mainstay of treatment for diarrheal disease is fluids. So we really recommend oral rehydration solutions. So I'm going to just talk first about that. So oral rehydration solution is really important to replace both the fluid and electrolytes that are being lost in the stool. So oral rehydration solution comes pre-made. Typically it comes both as packets of salt that you can mix with water, or as pre-made solutions. Pedialyte is a common brand in the US that we use. And it contains sodium, potassium, glucose, and citrate, which is a base. Generally, I would say if you don't know that the family has a source of clean water, using the pre-made oral rehydration solution is preferred than using the powder. But if that's not available in your community, just really emphasize to the family the importance of mixing the powder with a clean water source. And once the powder is prepared, it should be consumed or discarded within 12 hours if kept at room temperature, or 24 hours if kept in the refrigerator. If oral rehydration solution is not available, other options that sort of mimic it is you want something with salt and something with a little bit of sugar. So salted rice water, salted yogurt drinks, some broth, just make sure that they add salt to the soup, or sort of 50-50 unsweetened juice with a little bit of added salt. There is a special note with children who have severe malnutrition. The standard oral rehydration solutions that are on the market aren't recommended. And they actually recommend the World Health Organization using a special low osmolality oral rehydration solution. But that sort of would be harder probably to get outside of a hospital setting. And when you are giving the oral rehydration solution, you really want to make sure to give it slowly, because that decreases the risks of vomiting. So under the age of 2, you can sort of offer a teaspoon every 1 to 2 minutes, or even a couple of drops in the mouth. Older children and adults can take frequent sips from a cup or a straw. If the child vomits, just wait around 5 to 10 minutes and try again with a smaller amount. The one other thing to mention about oral rehydration solution is for cholera. Even though these options are fine, there's actually now a special rice-based oral rehydration solution that has been shown to have better outcomes in cholera patients. So how much oral rehydration solution should you give? So initially, that really depends on how dehydrated you think the child is when you see them in clinic. So if a child initially presents to you with minimal to no signs of dehydration, really you don't need to replace fluid losses already. It's only necessary to ensure the child maintains hydration by giving extra fluid for every loose stool to prevent the child from becoming dehydrated. And how much to give really depends on the child's age. And these are really just estimates, so that you see on the slide. So so you can tell the parents at home every time they have a loose stool, in addition to what they would normally drink or eat during the day, to give that little bit of extra oral rehydration solution. And one thing I would note is you want to ensure that at least they take some amount before they leave clinic, just to make sure they're tolerating it. If a child has mild to moderate dehydration, it's important to initially replace the lost fluids in the first 4 hours, and this should be done in the clinic setting prior to sending the child home. Then once the child tolerates these initial replacements in the first 4 hours, then you'd want to ensure hydration is maintained as per the prior slide by replacing after every stool. So ideally, the amount of fluid given in this situation is based on the child's weight, with the goal for the child to drink 75 mLs per kilograms over the first 4 hours. So for example, a 10 kilogram child, that comes out to 750 mLs of oral rehydration solution given over 4 hours. So if the child's weight is not known, you can estimate it based on the child's age. So of course, the exact fluid need will depend on how severely the child is dehydrated and how the child's responding, and also how much continued output this stool the child's having during these 4 hours. So this is why we always recommend this be done in the clinic setting, so you can have that frequent reassessment. While doing these 4 hours of rehydration, you also want to monitor for signs of fluid overload. So if you notice that the child's eyelids are starting to become puffy, that can be a sign of over rehydration. You want to back off. They can continue taking breast milk, plain water, but you don't want to continue that more intensive oral rehydration solution until the puffiness resolves. If the child is not fluid over and wants to drink more than the amounts shown on the slide, that is totally fine. And then, of course, as they're having copious stool outputs, you would also want to err on the side of being even more generous in the information given on the slide. So in addition to fluids, oral fluids, zinc deficiency, zinc has been shown to reduce both the severity and duration of diarrheal disease in children. And that's because zinc deficiency is widespread among children in developing countries, and can be lost at even higher rates during a diarrheal disease. And zinc comes in both syrups, tablets, powders, really none is preferred over the other. And typically you'd want to give zinc for around 10 to 14 days, with the dose being 20 milligrams for children over 6 months of age. Of note, the main side effect of zinc is vomiting, which unfortunately is already common in kids with diarrheal disease. So there was a study that I found from 2020 that showed that 5 milligrams or 10 milligram doses, regardless of age, was non-inferior to the 20 milligram dose with less vomiting, which would be advantageous. However, the current guidelines from the World Health Organization still recommends the 20 milligram dose. So that is something to consider if you have a patient with severe vomiting as a symptom, or families telling you they're not tolerating the zinc because of vomiting, maybe consider going down the dose to 5 milligrams. So the other thing, at least in the US, parents always ask me about is, does my kid need antibiotics? So the answer is, in the vast majority of cases, no. And the reason why that is firstly, a lot of diarrheal disease is caused by viruses like rotavirus. Also, parasites can cause diarrheal disease, and both of them don't respond to antibiotics. Also, even for bacterial causes like E. coli, most of them get better on its own. And then, in additionally, antibiotics can have side effects that can make kids just have stomach pain or other things that make them not want to eat and drink as much. And also on more of a community level, your increased rates of antibiotic resistance. So the antibiotics will stop over generations to stop working for diseases that they're really needed for. However, like all things, there are exceptions to the rule. So if a child comes in, probably the most common one in outpatient setting that you would consider antibiotics for is if they're coming in for bloody diarrhea, because Shigella responds beautifully to antibiotics. It reduces both the severity and duration. And you would have to know your local community susceptibilities, but in general, ciprofloxacin or azithromycin is the first line recommended antibiotics for Shigella. If you have a child with suspected cholera with severe dehydration, starting antibiotics as soon as possible is really important. And recommended is doxycycline, azithromycin, or erythromycin, again, depending on your local susceptibilities. The other thing, of course, if you are concerned for a non-intestinal disease, diarrhea just being one of those symptoms, or in select situations for those high-risk individuals. And generally for severe malnourished children, if they were hospitalized, they are generally started on broad-spectrum antibiotics to prevent complications. So other things that to consider in terms of treatment is importance of nutrition. So at least in my practice, a lot of parents ask me what they should feed their kids during the diarrheal disease. And it used to be that people recommend more of a restricted diet for during diarrheal illnesses, thinking that it would reduce the course or the severity. But the current evidence actually suggests that you really want them to eat whatever they're interested in eating, as really maintaining nutrition is really good. It's the best way for energy, and again, and actually has no, whatever they eat really doesn't affect their diarrheal course. So soups, stews, grains, rice, fresh fruits and vegetables, lean meat, eggs, yogurt are all recommended. In young children, really, if mom's still breastfeeding, that's a great source of nutrition. So encourage mom to keep that up. Or if they're formula feeding, encourage formula intake. The only thing that if parents ask that I would say are not recommended during a diarrheal disease is carbonated drinks, commercial juices with high fructose, corn syrup or stuff like that, like Kool-Aid or stuff like that, or very fatty fried foods, because that can all make the diarrhea worse. And in terms of how, the only thing that's generally is better tolerated is instead of like 3 or large meals a day, to give around 5 or 6 small meals a day every 3 to 4 hours, so they can better absorb it during the course of the diarrheal disease. If a child is presenting with mild to no dehydration, food can be given immediately in clinic. If a child has moderate dehydration, first you should make sure they're tolerating the rehydration the first 4 hours, and then give them something to eat before they leave clinic to make sure they're tolerating the food too. In terms of other treatments, really not that much is recommended. So we don't recommend any anti-diarrheal agents such as loperamide or anything else. They have no practical benefit and can actually be dangerous. So in terms of antiemetics or to reduce risk of vomiting, the World Health Organization recommends against it. And these are drugs like promethazine, metoclopramide, chlorpromazine. And the reason why they recommend against it is that they can have side effects such as sedation, neuropsychiatric side effects, among others. However, I have to say in the US, we tend to give antiemetics. And the reason why that is by lessening nausea, vomiting, oral intake, and rehydration can be improved, and it reduces the risk that a kid will need to progress to needing IV hydration. And I think one of the differences in terms of mentality is that we tend to use ondansetron, often brand name Zofran. I know that ondansetron might be hard to get since the price has come down a lot in the past couple of years from what I've heard, but it used to be an expensive drug. But it's very much of a safe drug and has less of the side effects than some of the older generations, which is why I think we're feeling more comfortable using it as an antiemetic in this situation, as it's actually been shown to, in the ED setting, reduce rates of remission. The only situation where ondansetron is contraindicated is someone with known QT prolongation. The other thing that is good if parents ask as a non-medication for vomiting is giving ginger, so they can take ginger liquid or ground ginger, and it's actually been shown to be almost as effective as ondansetron as an antiemetic. The other thing to consider is if your child is presenting with fevers, is that when you have a fever, it can contribute to dehydration, to spreading and worsen. And when you are febrile, people just don't feel like eating as much. So giving acetaminophen or another antipyretic can also help the family feel better, the child feel better. And then one last thing to consider in outpatient treatment is just keeping it back in mind if your child requires vitamin A supplementation. Most children do not routinely require vitamin A supplementation as part of their treatment. However, if you have a child with diarrheal disease who you know has a history of an eye lesion that's associated with vitamin A deficiency, has a history of severe malnutrition, or has a history of measles, they should receive vitamin A supplementation as part of their treatment regimen for their diarrheal disease. So I just want to change courses briefly to mention a couple of things about managing severe dehydration in the hospital emergency room setting. So firstly, if a child's in signs of shock, so if they're, these, for example, have altered mental status, looking lethargic, unconscious, is extremely tachycardic, thready pulses, low cap refill, low blood pressure, no wet diapers, really just looking crummy, immediate IV resuscitation is required. In this setting, typically lactate ringers is the preferred fluid solution, though normal saline can be used. And you'd want to give 20 mL per kilogram bolus, and then that can be repeated until the child's pulses are coming back, their cap refills improving. If the child is just severely dehydrated without those signs of shock, it is still important to start IV hydration, but you don't have to be as aggressive. If there's not a facility nearby where IV fluids can be given quickly, the best situation is to, if you do have the capabilities, is to place a nasogastric tube, or if not, by mouth, and just try to have the child drink as much oral rehydration solution as possible, or give it slowly through the nasogastric tube. And then, as soon as possible, get them to a location where they can get an IV. During the IV rehydration, you really want close reassessment to see if the child's responding in terms of mental status, in terms of if they're starting to have those signs of if they're starting to have better, lower pulses, better breathing, etc. As they are improving, you also want to have the child to start drinking oral rehydration solution as soon as feasible, usually within a couple of hours of them starting on the IV fluids. And that is because the one downside of lactate ringers is it doesn't contain glucose, and the potassium is often inadequate in terms of the amount to replace all the potassium they're losing in the stools. Lactate ringers contains base and also sodium chloride. So by giving the oral rehydration solution, you're making sure they're not dropping their glucose stores and replenishing the potassium stores. And then just one special note about treating patients with cholera. So these children often have very significant stool loss in the first 24 hours. So they will often require even more aggressive fluid management than the recommendations placed on this slide to keep up with those continued losses. So this is a nice summary slide from the Kenya government about how much fluids you should give based on the degree of dehydration. So if they're just having mild to moderate dehydration, like in Plan B, and you're giving oral rehydration solution based on the child's weight, that's how much you should give. If they're having severe dehydration, that's Plan C versus steps 1 and 2 in terms of orders of how much fluid to give. And if they're in signs of shock, that's how much to give immediately. So that's a good slide to keep for your references. So that is all for now. What questions do you guys have? And I can go to the chat. So I'll start reading out questions if that works with you. So I see in the chat, how else can you diagnose Shigella other than bloody diarrhea? So it can be, so you can do a stool culture if that's available to you. And you can look initially for sugar toxin on the stool culture, and then once it plates out in 48 hours, you should see Shigella on the stool culture. That being said, since stool cultures take 48 hours to 72 hours to come back anyways, and they can be expensive, the general guidelines is just if you see bloody diarrhea, presume Shigella and just treat for Shigella and not wait on confirmatory testing. So then from why are antidiarrheal drugs discouraged? So I think I mentioned before is they can have complications. So some of them can actually cause ileuses, which can cause a surgical abdomen. B, they actually don't do much. And also in some cases, you actually want to clear. So in E. coli, it can actually be long courses because you actually want to clear the bacteria. So that's really the reasons why. And they also, a lot of them can also cause sedation among other things in terms of why antidiarrhea drugs are discouraged. When should you use antimotility drugs, and what's wrong with giving the drugs to patients? And what age can you, same idea with loperamide? So in general, we don't really recommend it at all in young children. I don't really have a specific age. I truthfully never give it in my clinic. I truthfully never give loperamide or anything. I know in some adults when you're more concerned about traveler's diarrhea in that situation, you can give loperamide, but in general, I don't have a specific age group, but in children in general, we don't recommend it. We rather them clear and just rehydrate, given that it hasn't actually shown to have a clinical benefit in terms of their disease course overall. If that answers the question. When a child has acute diarrhea without fever, is it right to give probiotics alone? So I think probiotics are never wrong to give. I think with acute diarrhea without fever, you still would want to give oral rehydration solution to replace for the fluid losses. I would still give zinc in those settings. I think probiotics never hurts. I think it's one of those areas that has some suggestion of benefit, but the degree of benefit versus cost ratio to the family is questionable. That's why when some people like yogurt, especially because it does contain probiotics, if family wants to do something, sometimes I'll recommend culturelle if I was to consider probiotic, but I give it as this is more of a adjunctive treatment that you can try, but that might have evidence of helping, but the data behind them just isn't great that they do. They definitely won't hurt the patient. Let's put it that way. If they provide additional benefit, what's the cost? That's questionable. So now I'm going back to the other chat. I'm looking at both screens. Oh, sorry. Let me just click with this one first. I know some in the Q&A and some in the chat. Thank you, Zoom. Is interosseous access still applicable in a clinical setting in management of severe diarrhea and peripheral cannulation is not possible? Yes, IO is completely reasonable if you have the capabilities. It's a great alternative, especially in young children. The other alternative that we don't use that much in the US, but some settings are starting to use, if IV access isn't applicable, is actually sub-Q hydration. And that's an area that truthfully where I did residency, we never did, but I know a lot of areas, ERs are starting to consider that too. But IO is a great option, especially in young kids. Okay. How do you manage upper respiratory tract infections with diarrhea as antibiotics may predispose to it? That's a great question. I don't really have a great answer to that one. So firstly, in terms of upper respiratory tract infections, you have to consider is, do you think it's caused by bacteria or do you think it's viral? So if the kid has bronchiolitis, like less than 2, no focal findings, or just URI, you won't want to give antibiotics in that situation because it will have no benefit for the viral. If you're concerned about a true pneumonia that requires antibiotics, then you would want to give in that setting, with the caveat that you just let families know it might make the diarrhea worse. Give it as narrow spectrum as possible. So for a pneumonia situation, amoxicillin would be the preferred antibiotic. And in that case, you might want to consider probiotics along with the antibiotic as something to recommend. But yes, you are doing sort of a benefit risk calculation in your head in that situation. Kevin asks, if the child's in shock for more than 2 days, will you still continue giving fluids or you consider fluid overload? So hopefully no one should be in shock for more than 2 days. I think truthfully shock is something that should be repleted quickly, and then you're managing like your severe dehydration for continued output. I think you really have to manage see how the child's looking in that situation. So I think you have to see, are they showing signs of fluid overload, such as peripheral edema? And you can also, if you have weights, based on weights. So are their weights being stable? If they're increasing weights very quickly, then that would be a sign of fluid overload. This is beyond sort of the scope, but if you're still having signs of shock despite fluids and you're repleting fluids, showing signs of fluid overload, and their blood pressure is not responding, they still are having steady pulses, they're still having per cap refill, at that point you would have to consider pressors. The other thing to consider is just in terms of amount of fluid for a child in shock is they have a history of have kidney disease, which would put them at risk for being sensitive to excess fluids. And then one other thing about fluid overload is continually listening to the heart and lungs. If you hear any new, that's also a sign of excess fluids. This is going so well. So, okay, let's just keep with the questions who are on here right now. Hi, my name is Dennis. I have time. I'm at home, so I can probably take questions to the end of the hour. My name is it possible to prepare a presentation on allergy-induced diarrhea? So, truthfully, probably asking an allergist that question would probably be a better person than me, but just as a general statement on that, it's sort of, I wouldn't say that's a common cause of diarrhea. Sometimes you can see in very young babies a milk protein allergy that can cause diarrheal symptoms. And that typically presents with flux of blood in their stool, and often having moms cut out milk from their diet or dairy products from your diet while continuing to breastfeed can be a sign of that. But in general, in most situations in children, actually infectious causes are much more common than allergy-induced. So that would be one situation where you would consider possibly allergy-induced. Why is antiemetics discouraged? So I think I mentioned that before. It's really just because the older generations have had so many side effects associated with them that they actually showed the kids had worse outcomes due to side effects than actually any benefit. But like I said, if Zofran or Danceton's available, we do give it. Any kid who I see with vomiting and diarrheal disease in clinic, I would give them Ondansetron as in clinic and send them home with that. So, but I think the World Health Organization is still thinking that in a lot of parts of the world, they use some of those more older generation ones with increased side effects. So that's why it's still discouraged. HPET, and then last question that I see on this screen, unless I miss any, and if I do miss your question, I'm really sorry. Actually, I missed one other. Sorry about that. I'll get back to it. H. pylori has become so rampant in pediatrics. What do you recommend? So, yeah, that's actually, unfortunately, yes, that is true. It is becoming more rampant. I actually don't know if it's becoming more rampant or if it's just has always been there and we're just testing for it more. I'm not sure what's cause or effect there. But so in general, we don't actually recommend testing for H. pylori in most cases in pediatrics, because in general, a lot of people will carry it and it doesn't actually cause symptoms in a lot of kids. I know it's associated in life with an increased risk of gastric cancers among other causes. So unless you're having, so it's actually not recommended to test for it in children unless there's concerns for, say, severe GERD, not responding to appropriate treatment. They do a biopsy, the GI doctors, the stomach doctors notice H. pylori, then in some cases they'll treat it. The other thing about treating H. pylori in children is, especially if they're going to be in a environment where they're continually exposed to H. pylori, that increased risk of reinfection. So if you notice it once in their stool and they're still living around multiple family members, it's probably not causing their symptoms to begin with. So in kids, we tend to ignore it more than we deal, especially in young kids. In older individuals, then we will sometimes treat for H. pylori. But younger individuals, we tend to just presume that they are just going to live with it. How do you manage diarrheal caused by drug side effects, either such as antiretrovirals? I'm sorry, I have to defer on that question. I actually haven't cared for any patients Of care for patients with diarrhea disease as drug side effects secondary to antibiotics, as drug side effects secondary to antiretrovirals. I actually don't have any personal experience with that. So probably talking with the ID doc would be, and that would probably, if I was to just give a guess, that would probably cause more chronic diarrhea since on the meds forever. So unfortunately, so talk to that doctor about that. So sorry, Dennis, I don't have a good answer for that one. So in a case of diarrhea is caused by viruses, what can you appreciate in stool microscopy? So I don't know if you're available. Sometimes if they're caused by viruses, now we will do PCR testing on the stool. That being said, it doesn't really change the management that much because you say it's caused by rota. Yes, it's caused by rota. We still need to treat rota. But you're right. You won't see anything in stool microscopy in that case, but you would see something on PCR testing. I think I got all the questions. Did I miss anything, Malik?
No, Dr. Neeson, I think you covered everything. And on behalf of everyone who watched today and everyone at the Addis Clinic, we want to thank you for such an expertly produced presentation. We're already hearing so much feedback inside of our group chat. So many people were impressed. So thank you so much for taking the time to present with us today and answer these extra questions. For everyone after the webinar, a copy of this will be made available to you within 48 hours, as well as the attached presentation. If you have any additional questions, please just email the link that you were sent whenever you registered for this email, and we'll do our very best to get this question answered. But for everyone who attended, thank you so much, and I'll pass it over to our guest lecturer for closing remarks.
Thanks so much, guys. And also, if you have any specific questions, you can get my email and I can try to send you an article or something on the topic. I'd be happy to send links. And have a great evening. Enjoy time at home.
Thank you so much. Thank you, everyone. Have a wonderful evening/afternoon, everyone. Bye-bye.